Hello everyone, I'm Dr. Nalini Bansal and this is my first lecture on hepatopathology. In this particular lecture, we'll be dealing with the liver biopsy issues. So whenever we are getting a liver biopsy sample in our lab, we should be aware of the following things. That is how the liver biopsy is obtained, from where within the liver it is obtained, why the liver biopsy is performed, and the final question that comes is who is reporting a liver biopsy, and herein comes the experience of a hepatopathologist. So the first question is how the liver biopsy is performed. So liver biopsy can be taken in a number of ways. The first method is a percutaneous method, that is the most popular method, and it will give the best yield of the liver biopsy. What you do here is you put a needle through the skin into the liver and then you obtain either a cut of the liver tissue, that is called a true cut biopsy, or you can take a suction biopsy. Both of these, especially the true cut biopsy, will give a very good yield of the liver biopsy tissue, which is generally more than 1.5 centimeters in length. The second method of getting a liver biopsy is through the transvenous route. Now this is generally performed when the patient's INR is very high, if it is more than 1.5, and you cannot do a percutaneous biopsy because of the risk of bleeding. So then you put a catheter through the internal jugular vein and then you reach the liver and you obtain the course of the liver tissue. So that is called a transjugular liver biopsy. The third method of getting a liver biopsy is by the laparoscopic method, wherein if the surgeon is doing a gallbladder surgery and if he feels that the liver is not looking in normal, so he can take out a wedge of the liver tissue and he can send it to us for reporting. So the liver biopsy could thus obtain be percutaneous, it could be a transjugular liver biopsy, or it could be a wedge of liver, which is generally obtained at the time of surgery. Out of all these three methods, the best and the most happy biopsy is a percutaneous biopsy, because here the core size is good and it is a good thickness of the core is obtained. So this is how a true cut biopsy, that is percutaneous, or a TJLB will look like generally. A true cut biopsy will be a good core length, whereas a TJLB is generally a fragmented core in small tiny thin bits. So this is not a very happy biopsy when you will look at the slide this way. So then next question is coming on to ideal liver biopsy. So what is an ideal liver biopsy? Ideal liver biopsy is at least 1.5 centimeters in length. It should have more than 10 portal tracts and the width should be at least 14 millimeter. So do we really see all the time this kind of a biopsy where all the criteria fit in? No, we generally don't. So shall we start a Bethesda system for liver biopsy? Like this pap smears we do, that it is satisfactory but it is limited by any of these parameters, where the length is less, where the tracts are less, or where the thickness is less. So actually I feel this should not be done, because this is an invasive procedure and we should try to give out maximum of what tissue we have. So like if we see for TJLP, even if they are the fragmented cores, many times you will be able to pick up the desired area. So herein, like you see, in this particular we got just one nodule, but that is completely enveloped by the fibrotic area. So we'll be able to say that yes, this is cirrhosis, and whatever problem patient is having is because of this advanced fibrosis. Now the second question that comes is from where they are taking this liver biopsy. So if you see here, this is a pictorial representation of a liver which is having nodules of variable size and lengths. So if they take a liver biopsy from here, you could still get 2 to 3 nodules in your biopsy. But if the biopsy needle core goes here in a macro nodule, the biopsy needle will comprise of only one nodule, and then it will be difficult to assess the cirrhotic architecture. Though you can still say that based on the reticulin and other stains that we'll be discussing later. So the second thing is the sample variation from where they are taking this biopsy. The third question is why we are doing this procedure, though it is invasive. So then what is the reason why we are doing this procedure? So liver biopsy is a very important procedure, especially when the disease is diffuse parenchymal. If there is any lesion in the liver, space occupying lesion in the liver for which the cause is unknown, or for the assessment of fibrosis when they are giving therapy, and when the liver function tests are abnormal for which no cause has been found. There are many other reasons for which a liver biopsy done, but these are the major categories. Then the final question comes is who is reporting a liver biopsy, and here comes the experience of a hepatopathologist. So in this we'll be discussing this as the interpretation of liver biopsy. So let's move on to basic minimum for reporting. So when you are getting a liver biopsy tissue, there is certain things which are minimum for reporting. That is, you should take at least 2 levels of hematoxylin stain, especially the first and the last level. Then in between you should get a Mezen's trichome stain done. Other stains can be done as required, or if you are not a resource constrained area, you can do all the stains like Orsin, Retic, pars T, pearl stain, rhodonine, rubianic and Victoria blue stain. Now for the connective tissue in the liver, we need 3 stains, that is empty stain, Orcine and reticulin. Empty will tell you about the degree of fibrosis, however it cannot differentiate fibrosis from necrosis. So you need to get an Orcine stain done to differentiate the two. So here lies the importance of Orcine. Then reticulin will outline the reticulin fibers and it will help to delineate the liver cell plate architecture. So you will require a reticulin stain, and these are the 3 connective tissue stains which are routinely done for all liver biopsies. Then you do a pars stain, pars diastase stain, that is generally done to look for pars positive diastase resistant alpha-1 antitrypsin globules, especially in alpha-1 antitrypsin deficiency diseases. Pulse stain is generally done to look for iron within the liver, and rhodonine, rubianic are done for the copper stores within the liver. Victoria blue stain can be done for hepatitis B surface antigen within the liver. So we can do these stains as in when required, or you can also do a panel on every liver biopsy that you do. So moving on from this to normal liver biopsy. So this is a hematoxylin eosin stain of a low bar view of liver biopsy. This whitish area, which is an empty space, is the central vein. So you see here, and this area with little connective tissue is the portal tract. Now when you see this is empty stain, mesenteric stain for fibrosis. It is also very important for counting the tracts, because here you can delineate the connective tissue in a better way and they stand out apart from the rest of the liver parenchyma. So this is a central vein which has a very thin rim of connective tissue, whereas if you see this is a portal tract which has a relatively larger amount of connective tissue, and they could be seen as a bluish stained tract in contrast to the background red color. You can also use an aniline blue or a green color as a counter stain. So depending on which counter stain you are using for mesons, you could get a blue or green color. Then this is a high power view of the liver biopsy slide. So as we saw in the empty stain, this is a portal tract. And if you go from the portal tract towards the central vein, there are different zones of the liver. So this is called the zonation of the liver. Excuse me. So this zonation, the zone which is next to the portal tract is called zone 1. Then as you go away from the portal tract towards the central vein, the mid zone is called zone 2, and zone 3 is also called the perivenular zone, which is next to the central vein. So if you see from here, all the blood is coming from the portal tract. So if we see from here, the zone 1 is getting the maximum amount of oxygen, and as you go away from the portal tract, the amount of oxygen supplied to zone 3 decreases. So whenever there is any hypoxic injury, the zone that is most likely to be affected is the zone 3, because this is the least oxygenated of all the 3 zones. Now this is a high power view of the portal tract. In a normal portal tract, there is generally one bile duct, or there could be 2 bile ducts. There could be a hepatic artery and a portal vein. Now we can identify the artery and the duct as they are of the same caliber. The size of the duct is similar to that of hepatic artery. You could see 1 or 2 bile ducts as we see here, and you could see 1 or 2 arteries. And this is the portal vein, which do not have a round caliber. It is of any shape and sizes, and it do not have a wall in any muscular wall that you see. And in addition, there will be connective tissue stroma and presence of several macrophages within the portal tract. Normal portal tract inflammation is very minimal to scan, so you will just have few lymphocyte sprinkling or some sprinkling of lymphocyte, but not more than that. So normal portal tract is relatively bland with a good amount of connective tissue, bile duct, hepatic artery and portal vein. That is we call the triad of portal tract. Now just outside the portal tract, these are the hepatocytes, and the area where the connective tissue merges with the hepatocyte is called the limiting plate of the portal tract. So normally if you draw a line between the portal tract and the hepatocyte, so you will be able to draw a fair line demarcation between the portal tract and the surrounding hepatocytes, and that is called the limiting plate. Now this image is showing the central vein of the liver parenchyma. Central vein, as it is called as a central vein because it lies in the center of the lobule. So what is a lobule? A lobule is a hexagon of the liver which is defined by Kirnan when he joined several portal tracts and he gave a lobular structure of the liver. We will be discussing this in the first talk. And the vein, because it lies in the center of the lobule, so it is called the central vein. Now as we saw in the first slide also, there is very little connective tissue abutting the central vein, and the hepatocytes just come and sit on the central vein. So that is how you differentiate central vein from the tract, and you do not see any artery or duct over here, and they just come and emanate from it and arranged in a single cell plate architecture, especially in the adults. Now this is a pictogram which is showing the different zones of the liver. Zone 1, which is next to the portal tract, so it is receiving the maximum oxygenated blood, and zone 3 is away from the portal tract, so it is receiving the less oxygenated blood. Now the zonation of the liver is very important functionally, because there are certain enzymes which are present only in one particular zone. Like if you go for glutamine synthetase, it is present only in the zone 3. So when you do a glutamine synthetase IFC, you will see the staining only in zone 3 and not in zone 2 or zone 1. And similarly, you see cytochrome P450, that is an enzyme which is used for drug metabolism, that is present mainly in zone 3. Other than that, there are certain enzymes which are present in all the zones, but there is a gradual decrease in the levels of enzyme. For example, the enzymes for gluconeogenesis are present all over, but there is a gradient in which they occur in different zones. Now, this pictogram is to show that the hepatocytes have different surfaces. So one surface is towards the sinusoid, which is facing the sinusoid where the blood flows. The other surface is facing the bile canaliculi, where the hepatocytes are releasing the bile as the bile juice, and the other surface of the hepatocytes is just next to the adjacent hepatocytes. So these are the sinusoids. The blood flows from the portal venule and hepatic arteriole towards the central vein, and it flows within the sinusoid. So in the sinusoids, the blood from arteriole and the venule mix and it flows towards the central vein. And the bile from the hepatocytes, it moves from the perivenular region. In the hepatocytes which are there in the perivenular region, they will release the bile into the bile canaliculi, and then it will flow in the opposite direction towards the tract. So the direction of flow of bile is opposite to that of blood. And the area which is there between the endothelial cells and the hepatocytes is called the space of Dissay. Now, what is the space of Dissay? Now, this is a very important space within the liver, because a lot of importance has been given to the Dissay space in the recent time. Why? Because this Dissay space contains a cell which is called stellate cells. Initially, these cells were thought to be containing vitamin A storing cells, but gradually these cells have been found to be, they could transform themselves into myofibroblasts, and these are the major source of fibrosis within the liver. So this is the space of Dissay. It is named after the scientist who discovered it, that is a scientist, he was a German scientist, Dissay. And this space contains the stellate cells, the Kupffer cells, which are the macrophages, and it also contains occasional lymphocytes, and these are the endothelial cells. So this is the space of Dissay, which is responsible for the development of fibrosis within the liver. So that was the normal liver biopsy. So coming to the end of this talk, that is the points to remember. Now, whenever we are seeing a liver biopsy or we are getting a liver biopsy tissue sample in our lab, we already discussed, we should be aware what kind of a liver biopsy is this, whether it is percutaneous, whether it is transjugular, or it is a wedge biopsy. Then when the biopsy is processed, we should get at least a minimum of HE and MT stain for assessing liver biopsy. The normal portal tracts contain a triad of hepatic artery, bile duct, and portal vein. The normal ratio of bile duct to portal vein is 0.9 is to 1.8. That means you can have 2 ducts in every tract. The blood flows from the portal tract towards the central vein, whereas the bile flows in the opposite direction, from zone 3 to zone 1. There is no significant inflammation in any of the tracts, and hepatocytes are generally arranged in single cell plate cords in an adult. So that is about normal liver biopsy. Thank you very much.